Good morning, Colorado, and all parts wherever you are joining us from. It is 8 o'clock. We have a lot of good stuff to talk about today, and so I am going to kick us off. Again, good morning, and whether you are a longtime partner of the Colorado Health Institute, or if you are tuning in for the first time today because you're curious about health information technology, I am here to welcome you to our July Hot Issues in Health webinar series. Today, we are going to be talking about HIT, the Health Information Technology in Colorado. My name is Sarah Schmidt. I'm the president and CEO of the Colorado Health Institute. I'm clearly still firing up my engine this morning, so thank you, everyone. Hope you have grabbed your coffee and you are getting excited for today's conversation. We're talking about a big topic, and since I started at CHI about 13 years ago, and well before that, we as an organization have been working on this important issue and thinking a lot about it and working on it with our partners in some different ways, whether it be analyzing the impact of telehealth on access, quality, and costs well before the COVID-19 pandemic, developing trusted governance for sharing data, identifying and supporting new and innovative use cases, including things like how do we link clinical data with community data to evaluate outcomes of some of our programs, and really assessing what is the value proposition of these tremendous public and private investments that we as a community and as a nation have made over the last many, many years. So we have a lot to talk about, and we are excited to be here today with you. Those are some of the things that we think about when we think about HIT, but I'm curious what you think about when you hear that word. If you can, open up your chat and type in there who you are, maybe where you're coming from, if you're here with an organization, or if you're just joining as an individual who's interested. And what is the technology that you think about when you think of health information technology? So go ahead, open up your chat, get your thinking caps on, and let us know who you are, who's joining us, and then also what is some of the technology that you think about when you think of health information technology. And not surprising, one of the first comments I see in there is from our colleague, Heather Colwell at Contexture. I'm sure she's got a lot of things that she thinks about, but excited to see what other people are going to share, both with all of you, and then during our dialogue today. We will be covering there are broad topics that we know people are thinking about. We're going to talk about a variety of things. We're going to introduce some key concepts to really set the stage, and then we're going to do some reflection on Colorado's health IT journey, where we have been and where we are going. And some of the things I'm starting to see people put into the chat are some of those very things we want to talk about today. How do we think about partnership? What's the role of closed loop referrals, and who are referring to and from? How do we connect in our community partners with our healthcare partners? How do we make sure our healthcare partners are connected to one another? What are the systems that we're using? This is awesome. Thanks everybody for dropping some of your feedback in here. We're going to have a great conversation. We have a wonderful, extraordinary panel of strategists and users from across the state that are going to give us some great perspective around health IT in Colorado. We've already had a great conversation before we got started, so I know it's going to be a fun time. If we can move to the next slide, just to remind folks, if you are not familiar with the Colorado Health Institute, we are a nonprofit public health institute, and we strengthen systems and communities with trusted analysis and collaborative solutions to improve health. We do that through a few different ways, including answering critical questions, making sense of complex issues, and supporting others to reach actionable solutions. The question of health information technology fits squarely into all of these, and we're excited to be doing this with you today. Before I turn the floor over, again, really excited to see what folks are dropping into the chat. I would be remiss if we didn't flag that we have a lot going on in our world. We are swimming in a rapidly changing environment that is impacting all facets of health and people's health, whether it be direct through care and coverage, but also some of those other things that we know are critical in terms of budget issues, programs like SNAP, et cetera. And we use our webinar series to help all of you think about and dialogue and make sense of those issues and answer those critical questions. I want to flag that we will have an upcoming August webinar to really dive into the federal and state changes that are happening and how we can be working together, how to make sense of that. The date is still TBD. So if you aren't signed up for our Summon Up newsletter, and if you're not following us on the various social media platforms, please do that so that you can get the date and sign up and join us for that conversation. So with that, I'm going to hand the floor over to my colleague, Emily Johnson, who is CHI's Managing Director of Research, Evaluation, and Convening, who's going to get us kicked off for today. Thanks, everybody.
Thank you, Sarah. Hi, everyone. My name is Emily Johnson, and as Sarah said, I am a Managing Director at the Colorado Health Institute. I have been with CHI for over a decade, and both here and in my previous roles, my work has intersected with many aspects of health information technology. And yet I will be the first to admit I am not an HIT expert. I'm always learning new things about this field, both the subject itself and the current landscape. I know just enough to know how important this area is. And yet questions linger for me, as I'm sure they do for some of you. So as part of our health issues series today, we wanted to have the dialogue that Sarah described, which is an honest conversation and discussion around the health information technology progress so far, of ongoing barriers and of what we can expect next. And we wanted to bring you along on the journey I'm currently on, trying to wrap my head around this grand idea. First, I wanted to start with a definition of health information technology, because it's really hard to talk about these things without, starting with what we're talking about. And so to come up with a definition of health information technology, we really wanted to turn to the Colorado Health Roadmap for that definition. So turning to that, we want to acknowledge what a broad concept it is. I'm sorry, Joe, if you help me out with a couple of slides, 2 forward. So the most recent Colorado Health IT Roadmap defines health information technology in a way that acknowledges that broadness as a broad concept that encompasses an array of technologies, computer hardware, software, or infrastructure to record, store, protect, and retrieve clinical, administrative, or financial information. We saw a lot of this broadness reflected in some of the comments that you all just left in the chat, talking about both partnerships, closed loop referrals, and really just this very broad idea. So we're talking about electronic health records, we're talking about telehealth platforms, we're talking about patient portals, we're talking about health information exchanges. There's a wide range. And while they all have the same goal of leveraging technology to improve care, if we're talking about barriers or progress or changes needed, talking about these things distinctly can be very helpful, especially because not everything that matters for this broad array of technologies that we call health IT to work is a technology solution. And again, we saw this in the chat. Processes, relationships, connections, these are all key things that the technology is useless without. So you can build Instagram, but if no one has pictures they want to share, it's just ones and zeros sitting on a proverbial shelf. And so I can make the foolish attempt at an analogy that I'm sure will be ripe with imperfections. I often think about health IT in terms of transportation. It all starts with a person. So there's you and all of your health information. You are in a car, and by virtue of containing your health information, that car is your electronic health record. You and the car drive on roads. These roads go between doctors, hospitals, labs, and other providers so that they can access some of your health data and push health data back out. These roads represent the concept of interoperability. This already exists in so many ways. So for example, I would see my regular doctor at a Kaiser facility when I was pregnant. And then when it came time to deliver at St. Joe's, the hospital had my whole history because they shared data with Kaiser. And they pushed data back to Kaiser, so when I went in for a postpartum follow-up appointment, they knew the details of the birth. But what about systems that allow these data to go to more places rather than one-off interoperable exchanges? In other words, what if we wanted to build a highway instead of roads? This is where health information exchanges come in. So those are those highways that connect hospitals and providers and everyone so the cars can go between all of them. So if I can use my Kaiser and St. Joe's example from earlier, it's not just relying on that relationship between that clinic and that hospital. Had I been in Gunnison and had that baby in Gunnison, Gunnison Valley Health would have been able to access my records. And public health can track on my immunizations. And this isn't all relying on a chain of interoperability agreements, but it's all standardized and in one infrastructure. So it makes sense that historically the big investments in interoperability from the state and federal government have been in building these health information exchanges so that you have a highway connecting everything instead of just roads that go from point A to point B or point B to point C. And of course, roads would be no good without the traffic rules that govern them. You need traffic rules saying where you and your car, in other words, your health data and health record, can and cannot go. We don't want a free-for-all. It's understandable for you to not want your dentist knowing what you discussed with your psychiatrist. So we have to figure out what's allowed to go where, who's allowed to do what, and how we let people know. And in my analogy, this is data governance, really kind of figuring all of that out. And then you have, but then today I really want to focus on that highway, which are those interoperable health information exchanges. And of course, the data governance that goes with them, because it's really unsafe to drive highways without having traffic rules. I want to focus on these today because it's a place where we as patients don't always have great insight into progress or the status of this work. They're really complex, and yet we hear about them all the time as really this dream outcome of having so much of the work that we're doing come to fruition. As I said earlier, this is where a lot of the energy and investments in interoperable systems live, and having those interoperable systems just makes sense for efficiency and for health. This is, of course, not to downplay the importance of telemedicine or those other really important forms of interoperability in the health IT landscape, but just to focus us a little bit more for the rest of the hour. And I think it's helpful to start with some background on health information exchanges in Colorado just to set the stage. About 20 years ago, QHN was founded by 5 healthcare partners on Colorado's western slope to help these regional providers share data, to kind of build those interoperable roads between the 5 partners. Over the next few years, this grew into a health information exchange connecting 15 countries across the western slope. The same thing was happening with Cohee in the eastern and central parts of the state. And in 2022, Cohee becomes Contexture when they merge with Health Current, which is the health information exchange in Arizona. In 2024, so just last year, Contexture and QHN affiliated to create a unified health information exchange in Colorado. But then you also have the creation of the Office of eHealth Information Technology, or OeHI, in 2015. OeHI is tasked with coming up with a statewide health information technology strategy, including an approach to health information exchanges. OeHI was created in 2015 by then Governor Hickenlooper, along with the eHealth Commission. In their first decade, they've released a series of roadmaps detailing this strategy. One strategy that is probably top of mind for many of you is the announcement of the Colorado Social Health Information Exchange, or Cohee, last year. Cohee is the state's initiative to build a framework that brings together multiple data partners to develop shared standards and governance for exchanging health-related data. So now let's leverage the recent Colorado Health IT roadmap to learn more about the office's work, OeHI's work, and where they fit into this landscape. The Colorado Health IT roadmap was published, or the most recent version, I should say, was published in April and is available on the state website, but we'll summarize some of the key themes from it right now. The work was led by OeHI and the eHealth Commission. It does build upon previous roadmaps, including the 2021 roadmap, and includes a ton of community input. They spoke with over 500 folks across nearly 70 organizations. The focuses here are really on affordability, access, health parity through technology. And it identifies 3 goals for health IT in Colorado going forward. First, increase community engagement in health IT solutions. One iteration of this philosophy is how OeHI is rolling out the Colorado Social Health Information Exchange, or Cohee, work. They are starting this work with regional proofs of concept in 4 different areas of the state to see how communities leverage a social health information framework. So really taking a bottom-up approach to growing that exchange. The second is supporting data sharing that is secure and appropriate. This is a lot of that governance work, those traffic rules that we talked about earlier. And this assumes that there is an infrastructure in place to govern and apply data standards. So this folds into the work of building those technology solutions. And finally, fostering responsible innovation, seeking to combine keeping pace with technologies or new ways of using technologies with ethical considerations. The roadmap identifies 3 strategies for this. First, they noted the importance of policy advocacy, of identifying policy gaps and working with lawmakers or via public comment to address those. 2, directed funding like grant making or financial support for providers and community organizations to adopt health IT. And then third, collaborating with other state agencies to leverage shared goals and resources. And you'll see these goals and strategies reflected in the key initiatives the roadmap shares. For example, the care coordination via Cohee is closely tied with the directed funding that supports the regional proofs of concept. So there's a lot happening, and a lot of different roads are being built in accidentally keeping with the transportation theme between the roadmap and what we talked about earlier. You'll see here, in addition, an image from the 2021 Colorado Health IT Roadmap. So how does the arc of Cohee dovetail with the growth of health information exchanges like QHN and Contexture? To be a good steward of public resources, how does all of this merge with the interoperability superhighway? And then what does it all look like on the ground for providers and patients? And we also want to think about what changes as technology changes. And technology is not just becoming more sophisticated faster, but really fundamentally changing with things like generative AI. So with this stage set, I'd now like to turn to our panel to help us think through these big questions. And we really do have a stellar trio here. I'm not just saying that. I am so glad to welcome Stephanie Pugliese, Ashlie Brown, and John Cohee to Hot Issues in Health. Some quick intros before we get started. Stephanie serves as the director of the Colorado Office of eHealth Innovation, OeHI, where she leads the strategic planning partnerships and funding for the office in collaboration with the governor-appointed eHealth Commission. Located in the office of Lieutenant Governor Diane Primavera, OeHI is the coordinator and leader of health information technology policy, funding, and coordination for the state, and catalyzes innovation in the health sphere throughout Colorado. Stephanie's 10+ years in the public sector have been diverse, from the Tennessee Secretary of State's office to Denver Public Health Inspections, and has been grounded in working collaboratively to meet the needs of communities. Ashlie Brown is the Chief Strategy and Technology Officer at Colorado Access, where she leads strategic planning and technology initiatives to drive growth and operational excellence. She brings expertise in health IT, data governance, and integrated care systems, with prior leadership roles at the esteemed Colorado Health Institute and Mass Health. While she was here at CHI, she led our work on the topic at hand, and so I can vouch that she knows her stuff. And Ashlie is also on the state's eHealth Commission, so others can vouch as well. And finally, John Cohee is the Chief Executive Officer at Denver Health, where he brings more than 27 years of experience and leadership in healthcare operations and strategy. Before becoming CEO, he served as the organization's Chief Operating Officer and previously led a national outpatient therapy network and managed care program. Throughout his career, John has overseen the growth of hospital systems, outpatient clinics, and rehabilitation services across multiple states. He is passionate about expanding access to healthcare, improving health outcomes, and leading with a deep commitment to community and equity. So welcome to the webinar, y'all. I'm going to hop into the questions, but before I do, I want to note that if we have time, We'd love to take a couple of audience questions towards the end of the webinar. So if you are in the audience and you have a question, please submit it via the chat or the Q&A feature. My colleague Joe will be checking those out, and like I said, we'll include a couple if we have time. All right, and with that, we will turn it over to some questions for our panel. Welcome, everybody. I would like to just start with a broad question, thinking about health IT from your perspective, just to know what the biggest roadblock has been from your perspective in building the interoperable health information technology system of your dreams. And you can sort of interpret that as you'd like. So Stephanie, let's start with you.
Good morning, everyone, and thanks for having me. I think from my perspective, one of the most challenging approaches to interoperability is that we already didn't do it in a lot of ways, right? And so, especially in Colorado, we are very kind of individualistic and support communities kind of coming up with their own solutions, and from the state perspective want to support those instead of forcing down top down solutions, which I think is the right thing to do. And it does pose challenges down the road sometimes, right? So we get to this place where in various communities and healthcare systems, folks already have technology and workflow that work for them. And when we develop solutions or try to find shared solutions, it does become difficult to say, well, how do we do this in a non-invasive way and in a way that will continue to support the solutions that already exist?
Thank you. And can I just ask a little bit more there? Is that that sounds a little bit like you're describing some of the regional proof of concept approach. Does that is that observation related to that? And could you speak a little bit to that?
Sure. So for the Colorado Social Health Information Exchange, fondly known now as Cohee, that is a good example, Emily. So I appreciate that. Yeah, my coffee is still kicking in too. So I'm glad Sarah said that. I think that's exactly right. So from the state perspective, we've looked at this as, again, we already didn't build something that everyone will start using afresh, right? Folks already have solutions they use for social referrals. And so from the state level, we've worked with a vendor to develop a vendor agnostic system that will allow various types of file and data sharing. And then we are partnering with 4 community-based organizations or counties to help us figure out at what levels can we build kind of that state top-down system where we can get far enough to communities for communities to kind of meet us there, but not so far as to disrupt that workflow or disrupt what's already existing. Because really our goal with Cohee is that folks don't even know that they're using it. Which is an interesting sale for a system. We want to make it so you don't even know you're in it. But I don't want to go on and on about that, but there's a good start.
Yeah, no, thank you, Stephanie. And I'm sorry to put you on the spot. I know we'll talk a bit more about Cohee later. It just felt like a very apt example. Okay, Ashlie, same question. What, from your perspective, has been that big roadblock to the interoperable health IT system of your dreams?
Yeah, so from my perspective, adoption has been an enormous challenge, and I'll give you just one example. So we have a patient access API that allows patients to pull their health data from us as a health plan into a health app of their choosing. This has been live for 3 years, and we have had half a dozen people use it. You heard me right. About 6 people have used it in the last 3 years, and we're spending hundreds of thousands of dollars on this every year. So, I would be very tempted to turn it off, but we can't because it is a federal requirement. So it will be live for anyone who wants to use it. but people aren't. And I think we see this kind of time and time again where the technology exists, but then we don't get the adoption that we need. I think there's an upstream problem with governance, that we don't always have the right information in those systems to motivate people to use it. And then that creates a downstream problem with improvement. If nobody's using it, it's hard to know why or what could be improved to make it better. And so right now we're a little bit stuck with some of these technologies where they're out there, they exist, nobody's using it, so we're just kind of waiting for them to come. The if you build it, they will come principle hasn't quite turned out the way that we thought. And so that's really the biggest problem, I think, for moving things forward, is that we can't move forward until we get kind of the everyday people using their data and telling us how they want to use it differently so we can improve the systems.
Thanks, Ashley. John, same question to you. What do you feel like has been a big roadblock in seeing this all come together?
Thank you, Emily. Appreciate the question. Appreciate the opportunity to be here this morning. Appreciate Sarah, the invitation, Colorado Health Institute for bringing this forward. So everybody knows, I look at this through the lens of rural hospitals, right? Service Delta Health, we're in Delta, Colorado. So there's 5 main roadblocks that I'll talk on today, talk on a little bit more in the panel, but infrastructure definitely in our hospitals is a significant hurdle. Infrastructure, equipment, the ability to build a robust network. And then as you go out into our community that we serve, just the broadband issues that we have to be able to connect patients. Second, we work with kind of a patchwork of systems. So we're not fortunate enough to have a system like an Epic or a Cerner. So typically what you'll see in rural hospitals is you have Meditech, and maybe we don't have the Civil War version, but maybe we have the World War II version, right? Which is still old, and that doesn't serve, it serves hospital, but doesn't serve your outpatient and your specialty clinics. So PT therapy, they may have a web-based system. We may use like an Athena for all of our clinics. So just the patchwork of systems that we have to try to tie together, and the various places then that our patients see specialties. So they may have to travel outside of Delta. They may go to the VA. So talk a little bit more about that, but just the patchwork of systems we have and how spread out our patients can be. Third is just cost. Cost of staffing are significant barriers. Workforce training and retention of that IT team, and just a knowledge base. And then really just data sharing agreements and some of the governance structures, whether it's with participation in the HIE or the value-based care models with the payers, just the legal and administrative hurdles that are out there are really not rural healthcare centric when we come up with these models. So those would be some of the things that stick out to me.
Could I ask you to elaborate a little bit more on that last point about some of those models that are out there feeling like they don't incorporate some of the concerns that you have?
Yeah, and some of it, I'll just take the payer piece of it. The payer side of it, you look at a system, and I'll use Intermountain just because Intermountain is in our area, St. Mary's. They have a really nice system. So no matter where patients are within their system, they're able to track data and get it to a payer. So I'll use Humana. So Humana may use a scorecard, and we're measured, our success and our payment and some of our incentives are measured on us hitting these marks. And to hit those marks, you need the data to be able to know, like, where are we? One, what are those marks? Two, how do we track it? And do we have the IT infrastructure to track that data and to get that data easily to our teams? And so, like, who's doing that, right? You can't afford a data analysis. You don't have a structure that can systematically put that together in a user-friendly format. If you have it, you have to manually go pull it. then get it in front of the providers. So it just becomes a burden. And I don't want to say burden because it's amazing. We need to be able to track those, but we just don't have the infrastructure oftentimes to track those. It's a very manual, resource heavy burden on us, which we just don't have the team to be able to do that.
Thank you for that. So Jonathan and Ashlie, I wanted to dig a little bit more into, you all are sort of in the place where a lot of this is getting operationalized with Colorado Health Access and with working in Delta with the healthcare system. And so I was hoping you could both share a bit about how interoperable health information shows up in the work that you do today. You've alluded to the parts of this in talking about those big roadblocks, but yeah, just wanted to see how else it's appearing or dig in a little bit more to those aspects.
Yeah, absolutely. So Jonathan touched on one of the big ones for us, and that's quality measurement. So as a plan, we're very interested in how our members are doing and what the outcomes are, what are some of the process measures that we're tracking to make sure that they're getting high quality care. And we are starting to get some supplemental data, which includes lab results, EHR data, immunizations, things like that. But it still is mostly based on claims. So I think we're starting to see interoperability kind of trickle its way into our quality measurement efforts. But we're still really in a place where we're relying heavily on claims for administrative calculations of these measures. That really limits our ability to get to true outcomes. We will be kind of stuck in process measures and, how many widgets do we have? How many visits were there? Because that's what claims tells us, right? Is that a service was delivered. It doesn't tell us the outcome for the member. It doesn't tell us how their health, their vital statistics are changing because of the care that they're receiving. So we are really excited to see some of that supplemental data coming in. But to John's point, we're seeing it mostly from bigger systems. It's very difficult for smaller providers to shoulder the burden of those costs that it takes to get that supplemental data flowing. So that's something that we're really interested in figuring out how to improve and advance that effort. We also are relying heavily on our admissions, discharge, and transfers, or ADT, feed that we get from Contexture, the state's HIE, to help us with transitions of care. So understanding when our members visit the ED, visit the hospital, are they getting the care they need? Are they connecting with their primary care provider after that visit, to really get them into primary care, which we know is helpful for preventing future hospitalizations and ED visits. So that's a piece that is working quite well. So I think that's a bright spot, as the ADT feed is, for the most part, very reliable. We're not missing data there. We're getting that data from the hospitals through Contexture, and that's a huge win.
John, same question.
Yeah.
You talked about a few ways, but how else is it showing up today?
Yeah, it's really nice to be able to follow Ashlie because of just piggyback. And as you'll hear, we have about 4 areas for us. Interoperable health information, it's becoming just increasingly critical to how we deliver care, especially here in the rural areas where we have access issues, coordination, continuity of care. It can become more fragmented. And in your day-to-day operations, it shows up in a few ways. First, we use it to support our clinical decision making. Our providers rely on real-time access to patient records across the different care settings. If you have that, whether a patient was seen here in our system, or they were in a tertiary care center, a specialist, they were in an ED in one of the neighboring towns, having that data seamlessly integrated reduces duplication, it improves our patient safety, and it allows for faster, more informed decisions by our providers. Second, it plays a huge role in managing our chronic diseases and just the population health. Through the health information exchanges, and I can tell you, the mad props to QHN. It's the first health information exchange, and I've been all over the US in my almost 27, 28 years. I started when I was 2. kind of whirl around this industry, QHN has done an amazing job. Haven't worked with Contexture, starting that relationship now, and I hope that continues because they do keep a really tight track of our patients. So I appreciate that. But having that is critical to identify our high risk patients, track those outcomes, and let us intervene proactively. That's really important when we're dealing with patients who might travel to do those specialized care, but they depend on us on the day-to-day management of that healthcare. So the more we have that information at our fingertips, the better that can be. It's really the foundation for the value-based care. And I think that's what Ashlie was touching on. We're participating in various payment models that require just a lot of reporting and care coordination. And without that exchange, we really can't work well with Ashlie and other partners and community-based organizations. Rural hospitals are at a disadvantage. There may be incentives that are out there, but just the data that you learn from that can help drive and change care. Lastly, it's really a tool for keeping rural hospitals viable. We access outsized records. When we access that, we're able to reduce unnecessary imaging, labs, readmissions. That just means better outcome, reduced cost, and really just a smarter use of our resource allocations. So our resources are very small, and every dollar that we have and every minute that we can save for the provider counts. So I know technology is still evolving, but that's a little taste on how the interoperability for the health exchange is huge for rural hospitals.
Thanks, John. And I also wanted to dig a little bit more into the health information technology challenges that are specific to rural areas. And I know you've already addressed a few in your responses, but I just wanted to give an opportunity to share anything else that we sort of haven't talked about that you think is really important to consider from that rural perspective. And that
Yeah, I'll just dig again, just the infrastructure, the patchwork of systems, cost, staffing are significant barriers, workforce training. But I would say the biggest issue, if you had to pick one, it's really our patchwork of systems and the lack of interface in between those systems. Because our patients, like I said, might receive care in various places. They might go to VA, tertiary care centers, out of town, and some of those entities may or may not use systems that we're able to interface with. And really, it makes our care then and our day-to-day management of our patients really not as efficient as it should be and risky. So it may seem to others like we're not managing those patients well. Well, to be able to manage those patients effectively, our providers have to take a lot of time manually to figure out and kind of paint the picture in the story. The workforce training is huge for us and just retention. Just having that data analytics team, having that IT team to be able to manage these is huge. It's not just about having a tech, it's about having a staff who knows how to use the technology and gather that data efficiently. Turnover in rural areas for us disrupts continuity and it leads to like our use of Meditech is really underutilized. We have Meditech, yes, it may be an old system, but it's still a good system. But because we don't have teams that know it like A to Z, it really means that we're not getting as much as we could out of that system. So just a little deeper dive in just a couple of those.
Yeah. Stephanie and also Ashlie, in your role as an eHealth commissioner, I wanted to ask you both a little bit more about what's sort of coming in what we've heard about in the past year and what's coming in the immediate future. So specifically Cohee, the Colorado Social Health Information Exchange, and a little bit about the vision for Cohee integration with the health information exchanges that we looked at the history of earlier. And can you get specific on how you see Cohee working within existing infrastructures, either those HIEs or others? And Stephanie, I'll turn to you.
Sure. Thanks, Emily. So for Cohee, like I mentioned earlier, we're really aiming to build something to meet people where they're at. And so that includes partners like Ashlie and John, as well as the Health Information Exchange. And so we're really excited to work with the Rays. So again, Ashlie, and
Could I ask you to
three
define
others.
that acronym briefly, please?
Yeah, the Rays are regional accountable entities, and they are partnered with our state Medicaid agency to provide care coordination and other services. So
Thank you.
of course. So we are working with each Ray individually to figure out, what use case or population they want to focus on for the Cohee integration. And each organization is at a different point in their technology, journey, and has a different tech setup. And so we're really at an exciting point with this system where we have been pretty focused internally. We've been working closely with our state Medicaid agency, Healthcare Policy and Financing, fondly known as HCPF, and have been focused on really building the foundation of Cohee and working with a pretty specific population in the home and community-based service provider area. And so this is really, starting July 1st. So we're 2 weeks into kind of our next phase of working with these partners, both the Rays and then the proofs of concept that I touched on earlier, where we really are about to learn kind of the limits from the state side of, how do we, test the API sandbox that we have? How do we, work with flat files? How do we, at each level, how do we customize this system with as little burden on our partner as possible? And so again, we've really tried to take the technology burden from the integration side of our partners and shoulder that at the state, and make it a little bit of a self-service as well. So I mentioned an API sandbox. So an API is an application programming interface, for our friends who are not in the tech world every day. And that's basically a very quick or instantaneous file transfer, data transfer. And so, some organizations are very sophisticated, ready to go with those. They can experiment in what we fondly, the tech community, OeHI didn't come up with this, but call a sandbox, where you can kind of experiment with that setup. And then we have others who say, we don't have that capability yet, and we need to send you a traditional file. And we're ready for that too. So I think I may have lost the thread of your question. Does that answer what
No,
you
that does. I mean, it sounds like what you're really saying is that the focus on how all of these work together is on building the bridges, the APIs, what it may be, to meet everybody where they are currently at, given the sort of variance in, right? And I mean, even your cat was excited about APIs. So
she's a big API enthusiast.
It's like a big, I see it's big in your household. So, but am I? Did I sort of summarize that correctly?
Absolutely.
Like that seems,
yep.
Okay, yeah,
nailed it.
Thanks, Ashlie. Any other thoughts or things to add?
Yeah, so how this is showing up for us as a Ray and Health Plan is we are working with OeHI on 2 different paths to get connected. One is to get connected through Cohee to HMIS, which is the Homeless Management Information System, to get more information about our members who are experiencing homelessness. And right now we have kind of view-only access to HMIS. So our care managers are able to go in, look up a specific member and see what's going on with them, but we're not able to pull that data down in any sort of large file transfer way. That's what Cohee is going to open up for us. And then that allows us to do a lot more sophisticated things on population health and interventions for the entire population, rather than this individual care coordination, which will continue, of course. But we're able to really scale our efforts once we're able to scale our data. So we're really excited about that pathway. And then we're also working on a separate but related pathway with Aurora Mental Health and Recovery on getting screening data from AMHR into our systems. And screening data specifically means social needs screening data. And so that's data that is currently flowing through a few different ways, but it's really bits and pieces right now. We're getting social needs screening data from the hospitals that are participating in HTP, the Hospital Transformation Program, which is all of the hospitals. So that's exciting. We're getting that data through Contexture. We're also getting some Z codes, which are codes that providers can drop on claims to let us know what's going on with social needs. Those are really spotty. Some providers use them, most providers do not. And then we also do our own social screening with our members. But all of those data sources right now add up to less than 10% of our members. And we know our members are getting screened a lot more than that. So we're looking for ways to get that screening information and get a better view of what social needs our members are facing. And that's another really exciting thing that we hope Cohee can unlock, is really that network of screening so that we can have that bigger population view and really scale data on that side as well.
It's really helpful, both of you. I do feel like I would be remiss if I didn't ask all of you if you are thinking about the role of emerging technologies like generative AI. And so I'll just throw that question out and see if anyone wants to grab that one. Ashlie, you're already off mute if you want to start. Yeah.
Yep. So we see a lot of promise in AI, also a lot of things to be cautious about, right? We want to make sure that AI is never making decisions that a human should be making. So that's kind of one of our first guiding principles. We've stood up an AI governance committee to really think through use case by use case, what is an appropriate use of AI and what is that technology just really not ready for yet. And we also have an AI policy that guides our use of AI. So we're really thinking a lot about governance and how we dip our toes into this cautiously but optimistically. I think one of the promises of AI is to really help us manage all of the data that we have, because we have over 500,000 members and we have a lot of data on them. We have all of their claims. We're getting more and more of their social needs data. We're getting their admissions, discharge, and transfer data. We're getting their lab data. We're getting their immunization data. The list goes on and on and on. And we have a lot of analysts to kind of sort through all of that data, but it's too much, right? Like we can't see everything that's in that data, even with the 30-ish analysts that we have across the organization. So AI can really help us sharpen our detective skills and notice trends in that data that we're currently missing, because we just can't afford to kind of endlessly increase our analyst pool to dig into all of the data that we have. And as interoperability continues, this will become even more important because we're going to get more and more and more and more data. So we really need tools that can help us sift through that quickly, efficiently, and highlight some of those insights that we're currently missing.
Yeah, first of all, I love one of those data analyst people that you have, Ashlie. So we'll talk after. That'd be great. AI for us, and I think Ashlie hit it. It's really balancing the governance and the policy behind how do we safely roll this out. I'm a huge fan of using AI. I use ChatGPT a ton for myself. Saves me a tremendous amount of time researching, just coming up and generating ideas. In our primary care clinics, we've already started to institute it. So from a dictation system, we use Athena as a system, and they have a couple of AI tools that allows our primary care providers to not have to use a scribe, and scribes are expensive, right? So a scribe saves you about $60,000 a year, or any other expensive tool. It's a really easy tool, but it has to be monitored, right? And again, our primary care physicians that have used that, it's been able to save them about 25 to 30 minutes over the course of a day. And for them, that's huge. That's documenting that they don't have to do it at home. And it really then is able to balance it. I think you're going to see more and more and more of it in health systems. We're fortunate here that we're a little bit smaller, so we're going to be able to adopt it more quickly. Because we don't have to have meetings to adopt it. but it really is going to allow us to, as Ashlie said, just be more efficient and use our resources more wisely. Is it going to read when it comes to any kind of radiology? No, it's not going to be the reader. It's not going to be the interpreter. It's not going to be the one that then orders a test. But could it send you to a spot that looks suspicious if you use it and increase the efficiency and effectiveness? Absolutely. So I think you're going to see that more and more as the technology continues to be refined. It has a tremendous place. And from a resource allocation poor area in rural hospitals, it can really significantly enhance what we can do.
I can round us out. And on the other side of John's comment, the state loves to meeting things to death. So, you know, from internal to the state, you know, we're following the lead of our chief data office and our Office of Information Technology, and they're doing a stellar job of assessing risks, you know, benefits, and everything across the board. I think Ashlie nailed it around the governance piece. I think that's the most critical piece of thinking through how we're all using AI, both, you know, personally and professionally, but particularly professionally. And so OeHI is kind of dipping our toes into it as well. We worked with Mile High United Way 211 on a project this year to assess the ability of large language models to recommend interoperability of community resource inventory data, which was a really exciting opportunity because that data is really varied across systems and kind of known to not always be the most reliable. And it's very critical for Cohee, right? We need to have reliable resource data in there in order for referrals to go anywhere and be effective. And so, you know, I will be posting, I think, our report from 211 on our website as soon as it's kind of finalized and everything. But, you know, spoiler alert, it was not a one size fits all kind of approach. Like it was the best of the tools that they tested to kind of align those data standards and fields, but it didn't solve the problem like that, right? And I think that's an easy, right now especially, there's so much enthusiasm around AI, and it's kind of being presented in a lot of ways as a magic wand of, well, we have AI now, so we can just use it for that, or we can just put that in AI and it'll fix it. It actually won't. And so, you know, to both Ashlie and John's point too, we still need people involved and really in the middle of it to make sure that what we're using it for is not only appropriate, but also accurate. I mean, that it can take us down, you know, a negative path as well. And so I agree. I'm cautiously optimistic, and I think that it does hold a lot of promise. And I think it also is not the one size fits all magic wand that maybe we wish it was.
Yeah, would love many magic wands. All right. Well, I apologize to our audience. This has been a great discussion. We don't have time for questions. We have literally 1 minute left. So I would love just to close out with all of you, if you can say in 10 seconds or less, what has been the biggest achievement in the health information technology? I guess I should say towards building the health information technology system of your dreams. So kind of the reverse of that biggest challenge one, the biggest achievement.
Yeah, I think I'll just go real quick. I think that QHN and Contexture for the state of Colorado, without the information exchange, they're on the right track. They really do make it easier for our providers to get exactly what they need to be able to do what it is that we've talked about today. So hats off to them.
I will second that because I think, sorry, I jumped in because I want to say the same thing. We are getting a lot of really valuable data that we really rely on for our work through Contexture, the ADT feed that I've already mentioned, lab data that's giving us a better view into the health outcomes for our members. And also we're able to see that 360 view. Our care managers can go in and see records throughout the care ecosystem, like Jonathan was mentioning. So that's hugely helpful, and is really a huge step forward from where we were 20 years ago. So it's working.
Actually, great. Stephanie, you want to close us out?
Sure. And similar vein, but I think I'll zoom out a little bit and say partnerships. I think Colorado is a really unique place in that we have really scrappy partners who are also willing to try new things. And yeah, I think the partnerships make anything that we do a success together.
Thank you, Stephanie. All right, well, I would love to thank all of you for being here today as panelists and for the work that you are doing in this space. This brings our Hot Issues in Health July webinar to a close. This webinar recording will be available on our website later today for those who are interested. And with that, everybody have a lovely Thursday. We will hopefully see a lot of you next month as we are digging in deeper into the current legislative context that Sarah mentioned earlier. Thank you all.
Thank you.